Today we will speak about lookalikes and bone lesions. After all, we are looking at the gross morphology with the help of radiology, X-rays for example in this, with ultrasound waves and magnetic resonance waves, different kinds of modalities to look at the gross morphology of the organs from head to foot. And similarities do exist unless one looks carefully. For example, look at these two girls. Almost similar, except you have to put your mind into it, look into the details, except for the glasses. Everything else is common. So the radiologist should be very perceptive, should have a good eye, should look at the details of the image that he sees and then only interpret. Because if he miss one detail, the entire diagnosis will go wrong and the patient suffers because of that. Bone lesions. When you are talking about bone lesions, first you have to know the age of the patient, because certain lesions do not occur at certain ages. I'll give you an example. Supposing the child's skull, 5-year-old child's skull, I have multiple lytic lesions in the lateral view of the skull. Immediately it should not jump that it is a multiple myeloma. Supposing he is 50 or over, then you can say it is multiple myeloma. Like that, age is very important. And then sight. See, the bones, long bones for example, have a diaphysis, metaphysis, epiphysis. Certain lesions occur exclusively in diaphysis. Certain lesions occur exclusively in epiphysis. But most of the lesions occur in diametaphyseal region because that is the growing part of the bone. So one has to be careful in looking at the site of the lesion. It may extend all the way up and down, but look at the site of the lesion. And number. Supposing somebody brings a radiograph of the pelvis and you see a lytic lesion in the left iliac bone. And then how do you proceed? Is it solitary? If it is solitary, it is a different diagnosis you give. So depending upon the age, particularly after the age of 45, you have to look into the entire skeleton. Maybe there are multiple lesions. The patient may not be symptomatic. If he is symptomatic, that part only will take radiography. But he may be asymptomatic, but in your own mind, a 50-year-old man comes with a lytic lesion in the iliac bone, you have to think of myeloma, metastasis, lymphoma. Occasionally tuberculosis also can produce. Multicentric tuberculosis is not uncommon, particularly in patients with AIDS. So these things we have to keep in mind and look at the number. And nature of the lesion. Is it osteolytic or purely osteosclerotic or mixed? You have to determine. And matrix, center of the matrix. Is it just lucent? Is it trabeculated, like a soap bubble appearance? Or is it calcified? If it is calcified, is the calcification in rings, arcs, or nugget-like calcification, or serpiginous type of calcification that you get in infarcts? These are helpful in making a proper diagnosis. And then sometimes it is too lucent. Is it a lipoma? And then only CT can decide, because on plain films, everything may look lucent. And then margins. So you look at the edges or the margins. Is it thin? Or is it thick? Or is it untraceable? That is what we call transitional zone. If it is thin, preferably you think of a benign lesion. If it is vague, transitional zone is vague, you don't know where exactly to draw the line, then it's quite aggressive and think of a malignant lesion. If it is sclerotic, of course, it is more of a benign nature. Endosteum. In long tubular bones, you have got a endosteum, not only the periosteum, not only the cortex, endosteum. Endosteum, is it scalloped? Is it resolved? For example, in hyperparathyroidism, it may be resolved. Or is it splitting? Splitting cortex is not uncommon in infarcts. So trabecular bone, see, as we said earlier, the bone has got a cortex and the trabecular bone in the center or medullary portion. Trabecular bone, is it involved? Are they trabecally proper? For example, take the vertebral body. cortex is nice, thick and sclerotic and dense. Whereas in the center, you see the trabeculae. Are the trabeculae exaggerated? Are they running in a parallel fashion? Are they resolved completely? In those trabeculae, particularly in vertebrae, there are primary trabeculae and a secondary trabeculae. The secondary trabeculae are resolved first in any resorptive disease such as hyperparathyroidism, osteoporosis. And then cortex. If the cortex, sometimes chronic periosteal reaction may get incorporated in the cortex and the cortex may be thickened. Or localized, for example, say an osteoid osteoma, intracortical, the cortex may be thickened. So, or it is thinned in expansile lesion. For example, take an aneurysmal bone cyst. At the expense of the cortex, expansion occurs. So the cortex is thinned. Occasionally it may even break. So minute breaks also you have to observe. And then periosteum. In long tubular bones, there is periosteum, particularly in children, is rather loose. So any insult, let it be trauma, let it be infection, let it be inflammation, even malignancy, periosteal reaction occurs. And then there are varieties of periosteal reaction. Is it thin, linear type of periosteal reaction, which indicates acute? Or is it multilaminar, repeated episodes? For example, in Ewing's sarcoma, you get onion peel type of appearance to multilaminar. And the multilaminar, they are not uniform. Sometimes there may be breaks. Or is it triangular? Famous Codman's triangle, which is described in malignant lesions such as osteogenic sarcoma. But today we see Codman's triangle. Codman's triangle is nothing but the periosteum is elevated, and because of the elevation of the periosteum, the sharp piece fibers get calcified or ossified. And the host cortex is there. That is the triangle that is formed. And today we see in healing fractures or in osteomyelitis where the periosteum is elevated and you may get a subperiosteal hematoma or a new bone. So periosteum is important, and for example, if you take chondrosarcoma, the periosteum is velvety. That is, it is slow growing chondrosarcoma. So part of it gets incorporated. When it gets incorporated, it doesn't uniformly gets incorporated. It is carpet-like, wavy. Or sometimes you may get a Christmas tree appearance, perpendicular, sharpest fibers calcify in a perpendicular fashion to the tubular bone. That definitely indicates malignancy. And then soft tissues. Soft tissues, are they calcified? Are they dense? Are they lucid? And soft tissues, are they localized soft tissue swelling? Or diffuse spindle-shaped soft tissue swelling? So that is important to note about the nature of the soft tissues. And then etiology. When it comes to etiology, a student or a professor should keep in mind immediately. Of course, students takes some time to keep their mind, whereas a experienced person, a gray beard like me, can keep that in a computer fashion. Immediately, all things go. Is it developmental? Is it traumatic? Is it infective? Is it inflammatory? Is it metabolic? Is it endocrinal? Is it like that? A chain of etiological factors we have to keep in mind. And sometimes the cause may not be known, which we call idiopathic. But don't say idiopathic first, because if you don't know anything, you say idiopathic first. After eliminating all these, from congenital to acquired, from benign to malignancy, then only you say etiology not known. At that particular time, maybe a postmortem will show the etiology, but sometimes it is idiopathic. Concentrate on the toes of both feet. If you look carefully, the one on the left side, the epiphyses are not closed. So he is a young person. And the lesion is lytic, no doubt, with a sclerotic border, expansile, some trabecular margins are seen. And it goes all the way to the articular margin. So what is it? First of all, is it benign or malignant? And then, of course, we can rule out congenital lesion, inflammatory or infective. There is not much of periosteal reaction. So you should think of a benign neoplasm or a malignant neoplasm. The obviously it is slow growing because there is a reactive new bone at the sclerotic border. On one side it is slow growing, and the other side is a little aggressive, going all the way to the epiphyseal plate. And then in the center, there are thick bone. It's not just residual bone trabeculae, as if there is new bone formation. So in benign lesions, what type of lesion produces this? It's not calcific, and he's too young for a giant cell tumor, although it is going all the way to the articular margin. And then in giant cell tumor, you don't get such a thick sclerotic margin. So you have to come to a conclusion, it is an osteoblastoma. The child comes with some pain, not relieved by usual drugs, and then this is the lesion. One on your right side, obviously he's an adult because epiphyses are closed, maybe minimal osteoarthritic changes are noted at the first metatarsophalangeal joint, and then it is also expansile, similar to the one that you saw in the child. And the margins are eroded, soft tissue swelling is there, calcific densities are noted. An adult, when he gives, and the joint, the interphalangeal joint is almost destroyed and is extending to the proximal margin of the distal phalanx. And some calcific densities are noted. And this is gout. Gout not only involves the joint, but also it may involve the bone itself. That's why it looks like a tumor. It is a pseudo tumor of gout. Again, feet coned on the phalanges and the toes. The one on your left side, the distal phalanx completely disappeared. The proximal phalanx has got lytic changes, and there is a huge soft tissue swelling. So what is it? And again, he's an adult. You're going to see the degenerative changes at the interphalangeal joints or metatarsophalangeal joints. And it's again gout. It is so severe, the distal phalanx has completely disappeared, but the soft tissue swelling is there, although there are no calcific foci to indicate that there are tophi, but then it is lytic and it is involving two bones. An adult, you think of gout. Could be osteomyelitis. Yes, it could be, except there is no periosteal reaction. That rules out infection. One on your right side, again you see a lytic lesion in the distal part of the proximal phalanx, and the margins are sclerotic and scalloped. It is also expansile. It is going all the way to the articular margin, and diffuse soft tissue swelling is there. There is some reactive new bone. What could it be? Congenital or developmental? No. Infection? Possible because of the diffuse soft tissue swelling. The major difference between a tumor, or a malignant tumor, and osteomyelitis or infection is, in a malignant tumor, usually there is localized soft tissue swelling. Whereas in a inflammation, there is a diffuse, symmetrical, almost symmetrical type of soft tissue swelling. This is infection. But there is no periosteal reaction. But you see, one thing I have to make it clear, periosteal reaction appears easily and grossly in long tubular bones, not in the short tubular bones like the carpus or even tarsus. Same thing in phalanges also. There are more or less cuboidal type of bones. Though immediately you don't get periosteal reaction. Not that periosteal reaction does not occur, it does occur. It takes time. And we said it is tuberculosis. In tuberculosis, reactive new bone is less as compared to pyogenic osteomyelitis or in fungal osteomyelitis. Fungal osteomyelitis is chronic and indolent. So you get a lot of reactive new bone and a lot of periosteal reaction which may get thickened. And sinus formation may be there. So this is tuberculosis. Two calcaneae, we don't know the ages because the apophyses are closed. Obviously they are adults. The one superiorly noted, it has got a calcific nugget. Maybe ossification also. It's hard to tell just on plain films whether it is calcification or ossification. Majority of the calcifications may go into ossification. If you see trabeculae or cortical bone, definitely it is ossification. But in the absence of it, it's very difficult to differentiate. But anyway, let us take it for calcification. Calcification in a large lucent area. It is classical. Whenever you see such a film, particularly in the calcaneum, it is a lipoma of the calcaneum. Because of the liquefaction of the fat necrosis, you may get saponification of fat and then calcification in the center. Whereas down below, it is also a lucent lesion. It is rather expanding and aggressive as compared to the lipoma, and it is thinning the cortex below, and almost as though there is a break in the cortex. What is this? This again, it is in the anterior portion of the calcaneum. If you divide the calcaneum into two segments, posterior and anterior, it is in the anterior segment of the calcaneum, almost abutting the articular margin. So it is simple cyst. Simple cyst, although in the long bones occur in children, but in adults, this is a common place for a simple cyst of the calcaneum, as opposed to the lipoma of the calcaneum in the superior aspect. Again, two more. These are just to show examples. One on the left side is a small lucent area. One on the right side is again expansile. Both are simple cysts. Simple cyst to begin with in the left side, simple cyst expanding on the right side. Again, three films. One on the superior aspect is about 20-25 years old, expanding lesion, and all the way going to the posterior margin, and there is a thin septum. There are no calcifications. I wish there are some calcific densities. You could easily say it's a chondroblastoma. But then again, in chondroblastoma, only 1/3 of the lesions contain calcifications. So absence of calcifications does not rule out chondroblastoma. This is a proved case of chondroblastoma in a 25-year-old. Not only they occur in the epiphysis, they can occur in the apophysis also. Of course, here the apophysis is rather closed, just closed. The two pictures below, one on the left side is multiple lytic areas. In adult, there is some osteoporosis of the bones. And then if we look at the subcalloid joint, it is obliterated. And this is proved to be tuberculosis. One on the right side, on the inferior aspect, expansile, aggressive, cortex broken, soap bubble appearance, classical of giant cell tumor. So please differentiate. One is chondroblastoma, another is tuberculosis. Of course, soft tissue swelling is not well appreciated, and the third is giant cell tumor. Another two films. One on the left side, there are multiple areas, almost the entire calcaneum is involved. Multiple areas of lucency, but predominantly sclerosis. That means chronic, and the bone is reacting as though to fight for the lytic lesions. And this is a fungal lesion. Anytime you see such a lesion, whether in one bone or multiple bones, please think of fungal lesions. Although actinomycosis and mudromycosis are common, but mixed fungal lesions can produce this. Again, note, there is no periosteal reaction to think of osteomyelitis, acute osteomyelitis, or pyogenic type of osteomyelitis. Could be tuberculosis. Tuberculosis should not produce that much of reactive bone. Very rarely, maybe 10% of the patient may produce, provided they are under treatment, the resistance is high, low dose organisms. But this is classical of a fungal lesion. One on your right side, again, you see a lucent lesion, no definitive margins, and there are calcific or ossific densities anteriorly. You see multiple as though they are bone islands. What could this be? It is an adult and a lytic lesion in the calcaneum. Some calcific densities prove to be chondrosarcoma. These are not classical in the sense they are not McIntyre type of calcification or arc-like or ring. They are just oblong as though they are residual bone islands. Why should islands be there? Residual bone trabeculae you should see. One on your left side, please note, It looks like an exhastosis. This is the result of a chronic trauma, treated, healed, and then it produces exuberant type of new bone, simulating a exhastosis, but this is post-traumatic exhastosis. One on your right side, lytic area, cortex is broken superiorly, something like a moth-eaten, no definite periosteal reaction or new bone, although the proximal portion, say anterior portion, is a little sclerotic. This proved to be metastasis from carcinoma of the prostate. They can produce often, say 90% of the time, sclerotic lesions, and 5% of the time, purely lytic lesions too, particularly in young adults. Whereas the another 5% can produce mixed lesions. This is carcinoma of the prostate metastasizing to the calcaneum. Two fingers, both are index fingers. It doesn't make any difference, but anyway, both have to be index fingers. One on your left side is an adult, epiphyses are fused. What do you see? A lytic lesion in the lateral aspect, and in the center there is a dense lesion. The cortex is broken, soft tissue swelling is there. In fact, there is clubbing of the finger too. And this obviously, keep this, whenever you think of a diagnosis, try to keep that particular lesion anywhere else. For example, keep it in the cortex of the femur or tibia, osteoma, intracortical, not just osteoma, but osteoid osteoma. That's why that loosens the central nidus, cortex is broken. Because of the hypervascularity, you can get localized clubbing. One on your right side, again, a child. The epiphyses are not closed. Again, you find a calcific density. Here, there are multiple calcific densities. The swelling is localized, not diffuse like that, which you saw in the left finger. And then there is a hook-like process superiorly. Whenever you see a hook-like process like that, think of a chondromatous lesion. This is a periosteal or juxtacortical chondroma. Those calcific densities are chondromatous lesions. There is scalloping and there is localized soft tissue swelling. Juxtacortical chondroma, of course, there are some references. This is also called, as I said earlier, periosteal chondroma. Two wrists, one on your left side is a little tomogram. Again, you see a lucent lesion of the central nidus, classical of an osteoid osteoma. It can occur in the long bones commonly, but obviously it can occur in small bones too. One on your right side is peculiar. It's a child again, the epiphyses are not closed, but there is an extra calcification in the scaphoid, extra bone. And it's not calcification, it looks like ossification, part of it at least. What do you think of the lesion? There is no calcific mass to think of a chondromatous lesion, but still it is Trevor's disease, epiphyseal chondroma. This is an unusual case, but you have to think of that. Generally, they occur unilaterally on one side, particularly on the lateral side. There is also called dysplasia epiphysealis hemimelica, or Fairy-Bank's disease or Trevor's disease. Unilateral, as I said earlier. Asymmetrical, hyperplasia, epiphyseal exhastosis, they call it sometimes. Here there is no epiphysis for the small bone, but exhastosis can occur. Pathologically, it is osteochondroma, and knee, ankle, and wrist are the common sites. One on your left side is a foot, and on your right side is a hand. Right side, what is happening? The first toe, the greater, so-called great toe, is hypertrophied with soft tissue swelling. The bones are bigger, like almost like a gigantism. These two are called local gigantism. And then the one on your left side, namely the great toe, is in the case of neurofibromatosis. There may be generalized neurofibromatosis, but this particular localized neurofibromatosis, because of the hyperemia, the bones get bigger. Because it is a developmental change, they grow into enormous proportions until the growth ceases. One on your right side the soft tissue swelling of the thumb and also the index finger. But then there are some lipomatous, small lucent areas which indicate that it is a lipoma. This is lipomatosis. And lipomatosis also, because of the increased vascularity, you can get a gigantism. So please note, two types of gigantism. One is in neurofibromatosis, another is in macrodactyly in lipomatosis. Macrodactyly is another example in a child. KTW syndrome, macrodystrophia lipomatosa, a big name for localized lipomatosis, and of course in neurofibromatosis. KTW syndrome, you know what it is? Klippel-Trenaunay-Weber syndrome, where there are multiple venous anomalies, and because of the venous anomalies, the arteries may also be hypertrophy, and then you get this localized gigantism. Two hands, one on your left side, the middle finger is bigger, like the one you saw, but at the same time, there is cortical pitting. Whenever on a phone somebody describes, another radiologist describes, there is cortical pitting, be careful. It is bilateral. Bilateral in the sense on either side of the phalanges, and they are thick, and there is not much of a soft tissue swelling. This occurs in tuberous sclerosis. Also notice the distal phalanx is sclerotic. Tuberous sclerosis, otherwise called epiloia, is a triad of symptoms clinically: adenoma, sedation, and then you can get epilepsy and angiolipoma of the kidney, or tumors in any part of the body, including heart, brain, multiple potato like calcific lesions, ependymal lesions. And one on your right side is again a hand, just the epiphyses are just closed, is about 17 years old. But if you look at the finger or the fifth metacarpal, is expanding not locally, not horizontally, but vertically, all the way to the metaphysis. And there is little scalloping also on the medial side. And if you look at the matrix, it looks like a ground glass. Immediately in a child, a ground glass appearance, expanding lytic lesion, should think of fibrous dysplasia. Fibrous dysplasia can be monostotic, just restricted to one bone, or it will be polyostotic, or in particular in girls it is called Albright Syndrome, where there is fibrous dysplasia of the bones, there is skin pigmentation. In addition, there is sexual precocity. In the majority of the cases, these fibrous dysplasia lesions in the bones are predominantly unilateral. That's why Albright has named it as Albright Syndrome. Again, two hands. One on your left side, expanding, a lytic lesion, the soft tissue swelling. And then if you look at the rest of the bones, particularly the radial aspect of the middle phalanx of the index finger, there is subperiosteal resorption of bone. Whenever that occurs, think of hyperparathyroidism. So if it is hyperparathyroidism, what this expansile lytic lesion doing? Brown tumor. Brown tumor is nothing like the brown pigment is there in the pathological section because of the hemorrhage. This is a brown tumor in hyperparathyroidism. One on your right side, classical of a giant cell tumor. There is no calcification in the center to think of an enchondroma, although enchondromata are more common in the hands and feet, but this does not contain calcification, classical calcification we have described earlier, namely rings, arcs, and nuggets, and only residual trabecula are there, and the lesion is expanding all the way to the articular margin, classical of a giant cell tumor. Keep it in the distal end of the radius, it will be classical. Lower end of the femur, proximal part of the tibia, classical of a giant cell tumor. Particularly, in these cases you have to know the name. For example, on the left side, if it is 10 years old, you don't think of brown tumor. On the right hand side, if it is, say, another 10 years old, you don't think of a giant cell tumor. Then up to third to fourth.